Hi, my name is Katie Lee Huang, and we're next going to be discussing the cardiovascular anatomy and physiology. Let's get started. Let's start with anatomy, which for this chapter is pretty short with a focus on the coronary artery anatomy. This is a very high-yield topic because of how important it is in understanding heart attacks. We'll talk more about myocardial infarction later in the chapter, but for now, let's review the coronary arteries. The coronary arteries arise from the base of the aorta. The two main arteries are called the left and the right coronary arteries, and they branch into four important arteries you should know and are listed here. The left main coronary artery, or LCA, the circumflex artery, or the LCX, the left anterior descending artery, or LAD, and the posterior descending artery, or PD. First, the RCA normally supplies the electrical conduction pathways of the heart, including the SA and AV nodes. The LCA, which you can see here, supplies the lateral and posterior wall of the left ventricle. The PD supplies the posterior one-third of the interventricular septum and the posterior wall of the ventricles. The LAD supplies most of the left ventricle so that an occlusion in this artery can cause devastating loss of cardiac function. Importantly, it supplies the apex, anterior wall of the anterior ventricle, and the anterior two-thirds of the interventricular septum. In fact, this artery is sometimes known as the widowmaker because an occlusion here so often leads to death. The LAD is the most common coronary artery occlusion. The right dominant coronary circulation occurs in 85% of the population. This means that the RCA, which branches into the PD, supplies the inferior portions of the left ventricle. In 8%, the inferior portion of the left ventricle is supplied by the PD originating from the CFX. In the other 7%, the PD arises from both the LCX and the RCA. The coronary arteries fill during diastole, which is unlike every other place in the body. An easy way to remember why is that the ventricular contraction increases pressure in the arteries, causing them to squeeze shut, so they can only fill when the ventricle is relaxed. One last important note on the anatomy is that the left atrium is the most posterior part of the heart. This is important since pathologically enlargement can cause dysphagia due to compression on the esophagus or hoarseness due to compression of the laryngeal nerve. Now that we're done talking about the coronary anatomy, let's move on to physiology. This is the bulk of the cardiovascular section. These concepts can be pretty hard to understand, but they're important to know, not just for the exam, but also for clinical rotations and beyond. A good understanding of cardiac physiology is absolutely necessary, so let's jump right in with cardiac output. Now, there are going to be a lot of equations here, but the most important thing to remember about cardiac output is what it actually is. Cardiac output is a measure of the volume of blood that the heart can pump out in a given amount of time. Let's fill in more of the details. If the heart pumps more blood per beat, called stroke volume, cardiac output will go up. It will also go up if the heart beats faster, also known as heart rate, while still pumping the same amount per beat. So, to review, stroke volume times heart rate is the simplest way to calculate cardiac output. The Fick principle is another way to calculate cardiac output. It can be indirectly calculated by measuring oxygen consumption and is based on the fact that oxygen is extracted from tissues at a rate proportional to blood flow. This is a formula you should know how to use and should be memorized. The next equation relates three important things together: mean arterial pressure, or MAP, cardiac output, and total peripheral resistance, or TPR. If this equation looks familiar, it's because it's really just a basic equation of fluid flow, where pressure equals flow times resistance, where flow is cardiac output and total peripheral resistance is the resistance of the equation. Mean arterial pressure can also be calculated by the addition of 2/3 diastolic pressure plus 1/3 systolic pressure. Pulse pressure is defined as the difference between systolic and diastolic pressures. This is important because a high value, often called a wide pulse pressure, is associated with certain pathologies, the major one being aortic regurgitation. The pulse pressure is directly proportional to stroke volume. Another important thing to remember is that faster heart rate only increases cardiac output up to a point. If the heart rate is really fast, like with a ventricular tachycardia, there isn't enough time for blood to fill in the ventricles during diastole, so cardiac output actually decreases. Let's talk about cardiac output in more detail. This next fact really ties together a lot of the important information about cardiac output. The three most important variables to remember are contractility, afterload, and preload, which can be remembered with this mnemonic SV cap. Before we get into specifics, let's just review what each of these means. Contractility is a measure of how effectively the heart can pump out blood. Preload measures how much blood fills the ventricle before systole, and afterload measures how much resistance there is in the aorta to prevent blood from leaving the heart. These three factors influence stroke volume. Let's think about this systematically and bring it back to what we already know about myocardial muscle fiber contraction. The preload is the volume of blood in the left ventricle before it contracts. An increase in preload stretches the myocardic fibrils and optimizes the overlap of actin-myosin complexes. Therefore, an increase in preload will increase stroke volume. Afterload represents the force that must be generated by the myocytes to contract against the resistance in the aorta and other peripheral systems. Hence, if afterload is decreased, then stroke volume will be increased. Contractility is the amount of force that can be generated by the myocytes. Increased contractility will increase stroke volume. Here's a question to solidify your understanding. A 35-year-old man comes into the ED in hypovolemic shock after having sustained a severe gunshot wound. How do his preload and contractility compare to normal, and what is the net effect of his cardiac output? Let's walk through the answer to this question. Since this patient has lost a lot of blood, his preload will be low because there is less blood to return to the heart. In order to compensate, the heart will try to pump more efficiently, so his contractility will be increased. Since these two move in opposite directions, they have opposite effects on his cardiac output. But the patient is in shock, which means his cardiac output must be lower than normal and is returning less blood to his vital organs. Catecholamines increase contractility. If you remember back, catecholamines, such as epinephrine, increase the activity of the calcium pump in the sarcoplasmic reticulum. This increases relaxation of the fibers and allows for greater contraction of the fibrils. Increased contractility is related to increased intracellular calcium. Increased calcium allows for more binding to troponin C and moves tropomyosin out of the actin filament to allow for myosin binding and contraction. Similarly, a decrease in extracellular sodium decreases the activity of the sodium-calcium exchanger and thereby increases the intracellular calcium. Digitalis increases the force of contraction by inhibiting the sodium-potassium pump. As a result, intracellular sodium is increased and the gradient across the cellular membrane is decreased. Calcium exchange is decreased as in the example before and results in increased intracellular calcium. Contractility, and by proxy stroke volume, is decreased with beta-1 blockade and it decreases cyclic AMP. Heart failure, acidosis, hypoxia, hypercapnia, and non-hydropyridine calcium channel blockers also decrease contractility. Myocardial oxygen demand is increased by things that make the heart work more. This includes increased afterload, increased contractility, increased heart rate, and increased heart size as a way of having increased heart tension. Now, let's expand more on preload and afterload. As we mentioned before, preload is equivalent to the ventricular end diastolic volume, or the volume of blood before contraction. Preload increases with exercise, as well as an increase in blood volume and increased sympathetic activity. Afterload is equivalent to the mean arterial pressure, which is proportional to peripheral resistance. Venodilators, like nitroglycerin, are drugs that expand the veins, allowing more blood to pool and thus lowering venous return to the heart. This lowers preload and thus lowers cardiac output in a normal person. On the other hand, vasodilators like hydralazine are drugs that expand the arteries, lowering the mean arterial pressure. This lowers afterload, which will increase cardiac output in a normal person. Let's now talk about the Starling curve, which is a high-yield concept on the exam. This can be a confusing topic, but essentially this diagram shows that contractility actually increases as preload increases because the overlap of the cardiac muscle fibers is more optimal. However, in states of heart failure, this relationship reverses with high preload, causing a decrease in contractility. This explains what we talked about before because vasodilators lower the preload from the far right of the CHF curve to the middle, allowing for cardiac output to go up. This can be seen here in congestive heart failure, where patients without vasodilators would be located here, and with vasodilators can bring their cardiac output to an increased amount if they return back to a decreased preload. As we talked about before, contractility increases with sympathetic stimulation, catecholamines, and digoxin. However, there is a point at which contractility begins to decrease in the Starling curve, and this correlates with an overstretching of the muscle fibers. Also, there is decreased contractility with loss of myocardium, beta blockers, and calcium channel blockers. Now, let's go over ejection fraction. The ejection fraction is a measure of what fraction of the blood in the ventricle at the end of diastole that is ejected from the heart during systole. It's important because it's a measure of how well the heart is contracting, and it should normally be somewhere between 55 and 70%. If you see decreased ejection fraction, that means the heart isn't pumping well, which is systolic heart failure. Next, let's talk about resistance, pressure, and flow. Resistance, pressure, and flow is greatly emphasized in physiology textbooks. There are a lot of equations and relationships here that are important to understand, but instead of focusing on the equations that you can memorize, let's focus on the concepts. Ohm's law is a principle of physics. A change in velocity equals current times resistance. We can equate this to the circulatory system. A change in pressure is equal to the flow times resistance. Here we can see that the resistance can be described by Poiseuille's law. Importantly, resistance is inversely proportional to the fourth power of the blood vessel resistance. So even a small change in blood vessel size can cause large changes in blood flow and resistance. Here's a question. If we increase the radius by 2 times, what would happen to the resistance? Well, since resistance, the radius, would be equal to 2 to the 4th, this would mean that resistance would decrease by a factor of 16. Resistances in series can be calculated by adding the resistances together, whereas resistances in parallel can be calculated by this equation. The reciprocal of the total resistance is equal to the sum of the reciprocal individual resistances. The last important concept is viscosity, which is basically the thickness of the blood and can be roughly measured by the hematocrit. If blood becomes more viscous, maybe because there are more blood cells or more protein, resistance to flow will increase. In order to keep flow the same, the body has to respond by creating higher pressures, which explains the hypertension normally seen in these states. For total peripheral resistance, most of it is a result of the arterioles, and this regulates capillary flow. Next, let's talk about cardiac and vascular function curves. This next graph, which is a graph of cardiac function, really brings together a lot of what we've been talking about so far. It can be a confusing image, but the concepts described are really important. The graphs that increase from left to right are cardiac function curves, such as seen here. These are similar to the Frank-Starling relationship. These show that cardiac output on the y-axis is a function of end diastolic volume on the x-axis. Now, if we give a positive ionotropic agent, this would shift the curve upward, as seen here. and this would indicate an increased cardiac output. If we were to give a negative ionotropic agent, such as here, this decreases cardiac output and is seen here as a downward shift. The graphs that decrease from right to left are vascular function curves, such as seen here. These graph venous return on the y-axis as a function of right atrial pressure on the x-axis. Looking at these curves, increases in blood volume shift the curve to the right, whereas decreases in blood volume shift the curve to the left. Where the two graphs intersect, as in point 1 on the diagram, cardiac output and venous return are equal. Any increase in cardiac output must be balanced by an increase in venous return, and vice versa, in order to keep things in balance. Point 2 is a high output state where both venous return and cardiac output are increased. This occurs because of decreased total peripheral resistance, for example with exercise or AV shunt. Point 3, as seen here, is a low output state where both venous return and cardiac output are decreased, and this is occurring due to increased total peripheral resistance. This can be seen in hemorrhage before compensation can occur. Here at point 4, this corresponds to heart failure where there is a decrease in cardiac output. The cardiac output is decreased since there is a decrease in ionotropy. And finally, here at point 5, we're just highlighting that the x-intercept is the same as the mean systemic pressure. The mean systemic pressure is the right atrial pressure at which there is no flow in the cardiac system.